Hi, I'm Dr. Michelle O'Donoghue reporting from Medscape. Today aired the first of the LBCT sessions for our virtual ACC 2021 this year. And I think that a lot of the excitement was about the presentation of ADAPTABLE. So here to discuss the top line results, we have Dr. Skylar Jones from Duke University. Welcome.
Thanks, Michelle. Thanks for having me.
So for those who perhaps missed the presentation, do you want to walk our listeners through both just the rationale as well as the overall study design, and then we'll get into the findings?
Of course. So ADAPTABLE was a large pragmatic study. It was the first randomized controlled trial using the PCORNet infrastructure in the United States. So we enrolled patients with established heart disease and a common enrichment risk factor, to 81 milligrams or 325 milligrams of aspirin, and followed them for 26 months. You and I both know that aspirin is really the most commonly used medication for heart disease. And despite some observational analyses and some RCT results from particularly post-MI or post-PCI patients, we really didn't have the answer for stable ischemic heart disease. And so that's what we really set out to do. And we randomized 15,076 patients across these 40 centers. They look pretty similar to the patients we take care of in practice. So they're about a median of 68 years old, had common comorbidities like hypertension, hyperlipidemia, and diabetes. And about a quarter of them were taking dual antiplatelet therapy. So when we look at it, there was no difference in the primary effectiveness endpoint, which was all-cause death, hospitalization for MI, or hospitalization for stroke. And then there wasn't a difference in major bleeding. And this was defined by hospitalization for bleeding that required a blood product transfusion. So overall, no differences between the groups. Because of that, this neutral or generally neutral trial result, we recommend that the patients stay on 81 if they're on 81 now. There was a signal for those patients who have been on and stayed on 325 milligrams, who have tolerated it, to continue, that they actually did better. So we actually recommend that they continue 325 and talk to their clinicians.
Well, I think a lot of interesting things to dig into here. And first of all, congratulations, because, I think that one of the reasons people were very interested to see this trial presented was because of the pragmatic design. And I do want to discuss that in more depth. But so taking a step back, thinking about the aspirin question, there may be some who are saying, well, is this really unanswered? Did we not know the answer to this beforehand? Now, you mentioned the observational studies, and we'd had certainly a large amount of observational data through the years that suggested no greater efficacy with the higher dose of aspirin, and perhaps a signal towards more bleeding. And then after that, I guess we had current OASIS 7 more recently, a randomized trial suggesting that at least for the duration of a month post-ACS, that there was no greater efficacy for the higher dose. I think, if I recall, overall bleeding was the same, but there was a signal towards more GI bleeding, perhaps with the higher dose of aspirin. But I guess we don't really have anything in the long-term follow-up space. Is that correct?
Yeah, that's right. When we designed this study, there had just been published an NCBR paper that showed that 60% of people who were discharged for MI and PCI were sent home on 325. And as you know, there's a lot of inertia that occurs with changing doses of medications, including aspirin. So a lot of these patients we thought stayed on 325. Now, by the time we enrolled our population, primarily in 2017 and 2018, 85% of patients were on 81 or the low dose. And so, that was, I guess, something that we didn't expect. We thought it would be a little bit closer to 50%, but ultimately it did. It was the population that we enrolled.
Well, and I think certainly a lot of regional differences there too. I think that the U.S. has traditionally had a higher use of the 325 than our colleagues overseas, certainly. But let's talk a little bit more about the pragmatic design. There's been so much attention paid to the astronomical cost of conducting clinical trials. So I think that it's really to be commended that you were able to build this design within an existing infrastructure. Of course, some of the challenges that come with that is that you had an open label study, which of course always introduces some concerns towards bias. And then outcomes were collected without adjudication. Do you want to walk us through perhaps the outcome reporting and your thoughts on how reliable that component was for the adaptable results?
Sure. We collected information from electronic health records, from private insurance plans. We had 3 private insurance partners, and then Centers for Medicare and Medicaid. And so we were able to create basically a data matrix that allowed us to query these data sets for endpoints. So we used previously validated endpoint algorithms to identify myocardial infarction, as well as stroke and major bleeding. And so, the major bleeding endpoint wasn't the most common one that I adjudicate every day, but it was kind of necessary. We needed to create something that we could actually program and capture in the data sets. So that's why we tagged it with a blood transfusion.
So I think to your point, it is notable that when we talk about the safety of the 325 versus 81, on the bleeding side, really you're restricting that to hospitalizations for bleeding requiring transfusion. That's correct?
That's right.
And beyond that, I suppose we don't have information about, for instance, nature of bleeding. So there had been that suggestion towards more GI bleeding in current OASIS 7. We're not going to be able to get that level of granularity. Is that right?
Well, there will be some evaluation of that. We do have reasons for why patients discontinued aspirin, and so and it was it was varied. Some of it was preferences. Some of it was other medical illnesses like atrial fibrillation or cancer that led people to change. But about 20% of the responses are do revolve around bleeding or bruising, and so we're going to evaluate that more.
Well, that'll be great to see. Yeah, I'm sure that you'll have a lot more analyses to come. Certainly, thinking about enteric coating, which is a hot topic, whether or not that influences efficacy or safety, and then also thinking about body weight and other factors that may come into play as well. So, I know that there's certainly more to come.
Yes.
One important point that has been raised is the fact that there was a high degree of crossover. And I think that that's certainly one of the challenges of having an open label study. So, do you want to perhaps just talk about what proportion of patients crossed over from the high dose to the low dose and what you think the implications are?
Sure. Yeah, there definitely was dose switching, and it was more common in the 325 milligram group. So about 41% of our participants did switch at some point during the study from 325 to 81, whereas only about 7% switched from 81 milligrams to 325. So differential effects or differential switching. We think that it may have implications for how we interpret things. That being said, we're looking at all the information as we do analyses on adherence and dose switching and outcomes associated with that.
And since the recommendations for ticagrelor specifically are to use 100 milligrams or less of aspirin, were those patients excluded from the study? And should anybody extrapolate the results to that patient population?
Yeah, so we set out to not have very many inclusion and exclusion criteria. In fact, Adrian Hernandez, at the time that we designed this, said we really don't want to have anything more than 1 or 2. We actually posted the protocol publicly to allow everybody, anyone and everyone, to look at it, and that was by far the most common kind of concern that we had from the public posting, was that cardiologists didn't feel good about randomizing patients to who are on ticagrelor to a higher dose. And so we excluded it, just like we excluded oral anticoagulants. And so I guess to answer your question, no, the study really isn't applicable to patients who are on ticagrelor.
So perhaps my last question before we wrap up is you made the point about how you posted the protocol to get open feedback. So I think one interesting part of this was you really tried to engage the patients in the overall design of the study and conduct. So maybe just touch a little bit further upon that and how that may have helped conduct the study overall.
Yeah, I hope you can see my smile. It's this is by far one of the most fun parts of this. It was incredibly, there are incredible lessons when we partner with our patients to design and conduct research studies. And so we had 9 patient partners. They were from each of the 9 research networks. And so each network was able to nominate one. They met every other week throughout the entire study. They looked at the protocol, they revised the protocol, they looked at patient-facing materials, they helped design the internet patient portal, and they're co-authors on the New England Journal paper. So we really feel like that part of it was really a neat piece. I did want to tell you a quick story. When we were sending initial contacts or to eligible patients, one of our patient partners got the invitation and said, "What are you guys doing? This is a white envelope with Duke University on it or some university. It looks like a hospital bill. Why would I ever even open this?" And so they helped us redesign it. We put colorful pictures. We spoke in language that really spoke to the patients, and so that was a really enlightening part of our experience. But yeah, it was a great piece of Adaptable.
Yeah, well, I think it certainly has opened our eyes, right, to so many aspects that have maybe been ignored in the past. So certainly a very important learning experience, I think, through Adaptable, and no doubt will be turned to for future trials in terms of trying to implement these types of changes. So again, congratulations on the trial as well as the New England Journal paper, and we look forward to seeing more analyses as we go along. So
Awesome.
wrapping up from Medscape, this is Dr. Michelle O'Donoghue.